I would like to invite Dr. Praveen Raj to speak about bariatric procedures other than the sleeve and bypass that we talked about today.
Good afternoon, friends. I think we are ahead by schedule of an hour or so. So I think we can spend some good discussion at the end of the session. So I would be talking on other bariatric procedures other than the commonly done sleeve gastrectomy, gastric bypass, and the mini gastric bypass, which we normally, I mean, it's much more commonly done. Is there really a role for other bariatric procedures other than these procedures is what we'll be talking. So these three are probably considered the most commonly done. I wouldn't say standard, but the most commonly done: sleeves, the Roux-en-Y's, and the minis. But then each has their own issues by itself. Sleeve is a good procedure, but then end of the day, it cannot be the best for super obese, for people with severe metabolic syndrome, etc. Roux-en-Y gastric bypass, considered to be the gold standard, but it has its dumping syndrome issues. You have the remnant stomach in the gastric cancer endemic areas. It has its own concerns. Then with the mini gastric bypass, yes, you have the bile reflux issues, which we still haven't figured it out. So is it all right to put it on a young patient? The malabsorptive issues has been discussed about. So each has their own share of bad things. Each has a good share, I mean, it has a lot of good things, and that is why they are the most commonly done operations. But is there a role for something beyond this? But when we look at the good and the bad of these, you have the sleeve, very good, but then sleeve may not be adequate. But if we can combine the good things of all this, but remove the bad things, probably we're looking at the other possible operation, what we call pylorus preserving bariatric procedures, which means do a sleeve gastrectomy and additionally you manipulate the intestine in different configurations. Each has a different name, let's not get into that. What we call the pylorus preserving procedures. If this is done at the jejunal level, you call the proximal single anastomosis pylorus preserving procedures. If it's done at the ileal level, which is much distal, you call it the distal single anastomosis pylorus preserving procedure, called the PSAP and the DSAP. Of a simple understanding of what's much more commonly spoken about, the language for easier to understand, what we would call the sleeve plus. You do a sleeve gastrectomy, you manipulate the intestines additionally to get the metabolic benefits from the intestine, because we all know the intestine is the largest endocrine organ of the body. When we know what it does in the right configuration, we can get those benefits. So sleeve plus is a much more commonly discussed entity for better understanding of what we are talking about in the other bariatric procedures. Some of the procedures, I wouldn't be showing the videos, but just for understanding, one is called the sleeve gastrectomy with transit bipartition, which is similar to a duodenal switch, but the anastomosis is done in the sleeve gastrectomy, not in the duodenum, but in the sleeve gastrectomy, technically more easier compared to the duodenal anastomosis. The same thing can be done in a loop configuration where the ileum is anastomosed to the sleeve. I am against this. I don't want the contents to put into the sleeve, but this is a procedure that's being done even in a country like India, what we call the sleeve gastrectomy with the loop bipartition. Another procedure called the sleeve gastrectomy with a proximal jejunal bypass, where you have a long blind loop of 250 to 300 centimeters, and then you do a sleeve along with the jejunostomy. This is called the proximal jejunal bypass. Again, done at a few centers in our country. Again, you have a long blind loop. Blind loop syndrome has their own concerns. So I'm not a proponent of these. I'm just telling you what are the different procedures that's available. And of course, we have the ileal transposition surgery, which is almost dead at this point of time, where you transpose an ileum or interpose the ileum proximally to get the GLP-1 benefits, primarily in terms of diabetes. But I think this was spoken about 7-8 years back. It was very popular. Few centers in India did, we did. But at this point of time, this is not being done. But then the two procedures I'll be showing you the videos would be a duodenojejunal bypass and a single anastomosis duodeno-ileal bypass, wherein we do a sleeve gastrectomy and we do a loop duodenojejunostomy, which is a proximal SAP, and a SARDIS, where it will be a single anastomosis duodeno-ileostomy, which is the distal SAP. I'll be showing the videos and I'll be explaining why we do these procedures as such. The port positions are similar to all other upper GI procedures which we do at our institute, and we stand in between the legs of the patient and reverse Trendelenburg. So I'll be first talking to you about the duodenojejunal bypass. So why do we do the duodenojejunal bypass? So duodenojejunal bypass, we have a sleeve gastrectomy, and we all know a sleeve gastrectomy works really well. So I wouldn't be getting into the steps of the sleeve gastrectomy. Sarfraz showed you a beautiful video. We'd be getting into, from mini gastric bypass, we all know that 150 to 200 centimeters of biliopancreatic limb helps from the metabolic standpoint. But then we cannot be doing it on young people because putting the bile into the stomach, we do not have long-term benefits, bile reflux, gastritis, and issues. So instead of doing the anastomosis at the stomach level, here it's a sleeve gastrectomy, so we have a long pouch similar to a mini gastric bypass, but the anastomosis is done at the duodenal level. So you mobilize the duodenum, so that is what you're doing. Subsequent after your sleeve gastrectomy, you mobilize the first part of the duodenum, and then have a cuff about 2 to 3 centimeters of duodenum. Try to get your staplers which is perpendicular to your duodenum. You'll have a very good division, because sometimes surgeons bring it from the left side of the abdomen, then you have to articulate your staplers, it becomes much more difficult. So you divide the duodenum at this point. White stapler should be good enough, but then I sometimes go one extra just for the comfort of it. So once the duodenum is divided, then you make a cuff, because the aim is to do an end-to-side duodenojejunostomy. So the indications for this procedure in my center are young super obese. Why I'm particularly saying young super obese, young people, I do not want a mini gastric bypass, and a super obese, a sleeve gastrectomy may not be adequate. You might most likely need a second stage operation. In a country like India, most people would not prefer a second stage operation when we talk it at the first stage itself. So on the young super obese, we do a one-stage single anastomosis sleeve along with the duodenojejunal bypass. And the limb length is usually around 180 centimeters. And this learning, we got it from the mini gastric bypass. We had a beautiful review of mini gastric bypass from Kamal Mahavar, who clearly said around 180 centimeters of limb length is ideal to balance weight loss and nutritional complications on one end. If you start going beyond 180, the nutritional complications are more. You start going less than 180, lesser than 150 to be precise, then your weight loss may not be adequate. So we take that learning from mini gastric bypass and do the anastomosis at the duodenum. Earlier when we started, I think Kasama from Japan was the first surgeon to demonstrate, to publish these results in the beginning of duodenojejunal bypass, because he comes from a country where gastric cancer is endemic. He does not want to put a Roux-en-Y gastric bypass and leave the remnant stomach. So they do not do a Roux-en-Y gastric bypass. Either it's a sleeve or sleeve plus a duodenojejunal bypass. He still continues to do a Roux-en-Y configuration. We started doing Roux-en-Ys, but then when there's the pylorus that is intact, you really don't need a Roux-en-Y. A loop duodenojejunal bypass should be good enough. But then I always prefer to do whatever Roux-en-Ys if it is into the stomach level. The anastomosis is a single layer. This was in fact done in a workshop. That's why you have the PIPs there. Usually we do the posterior layer interrupted, because many times posterior, in case when you do a continuous, you tend to make it loose. Coming and putting in added stitches posteriorly is extremely difficult. So the posterior layer is always interrupted. Of course, single layer. And we also do this procedure for I would say lower BMI patients. We started doing this more so for the lower BMI diabetes, but then recently our numbers for super obese youngs is now increasing. So as a standard on all the young super obese is anybody above 50 BMI, and more importantly after 60 BMI, we go it as a single stage procedure along with a sleeve gastrectomy as an option. But if the patient is quite understanding of the possibility of a second stage, then we might just do a sleeve gastrectomy, come back. If need be, we will do a revisional surgery, and that is where I'll be talking to you about the SARDIS procedure, which is my subsequent video that I'll be showing you. The anterior layer will be a single layer continuous. This is not going to be interrupted, only the posterior is interrupted. Again, because I'm showing these procedures does not mean I'm not doing the bypasses and the mini gastric bypasses. My topic was on the other bariatric procedures. You cannot fit one shirt to all the patients. You probably need to have different procedures into your armamentarium, because at the end of the day, the best procedure is the procedure that best suits the patient. And we cannot just say, I would just do a sleeve or a bypass in my center, because each patient profiles are different, the eating patterns are different, the responses are different, the geographies are different, so many things are different. So we need to see which procedure would rightly suit each particular patient group, which is what we are all trying to figure out, what will best suit the patient. So I just want to give an understanding what are the certain thoughts that we have in choosing these operations as such. And then yes, we'll be doing the leak test, and that would be completing the procedure as such. So the next procedure I'll be showing you is a SARDIS, which is a single anastomosis duodenal-ileal bypass. It's going to be a short video. The technique is similar to what I showed you, but it's not the jejunum, but it's the ileum. Although this was primarily proposed as a single stage procedure for morbid obesity and more popularized by Antonio Torres, the past IFSO president from Spain, I in my center do it primarily as a revisional procedure post-sleeve gastrectomy, because this is way more malabsorptive, especially in a patient where the sleeve gastrectomy has failed. I'm saying sleeve gastrectomy has failed in the sense you have done a beautiful sleeve gastrectomy and the patient has not lost adequate weight, what we will call inadequate weight loss, not patients who have lost adequate weight then regained. So that means the patient has failed. We need to differentiate patient failure versus a sleeve failure. So the concept of restriction has failed in the patient, so we are adding a concept of malabsorption. And when you're adding malabsorption, you need to be properly malabsorptive. So this is where we do the SARDIS. From the IC junction, we measure backwards 250 to 300 centimeters. I would normally measure the whole bowel length. If the bowel length is long enough, I would probably do 3 meters backward from the IC junction. But then if it is probably about 5 to 6 meters or less than 6 meters, I would probably do 250 centimeters, but not lesser than that, like what you used to do in the biliopancreatic diversion, where it's usually between 50 and 100 centimeters. So we do proper malabsorption. We don't revise the sleeve, because you end up adding more restriction and causing malabsorption. The patient will not be able to compensate the malabsorption, because the patient would need a lot of nutritional intake to compensate for the malabsorption. So this, we usually do it as a revisional procedure for failure of a sleeve gastrectomy. So these are some of the procedures that you can consider in our setting, especially preserving the pylorus has its own benefits, and there are so many procedures designed around it, but I just showed you 2 procedures for your understanding, but there are many different procedures that you categorize as sleeve plus procedures. And thank you all for your patient listening. We'll be happy to take any questions.
Thank you, Dr. Praveen. Excellent talk. Briefly summarized the 2 most appropriate other bariatric procedures. Any questions from the house?
Very good presentation, Praveen, as usual. What is the common channel you keep in SADI?
SADI, I keep 250 to 300. So I normally measure the bowel length. If the bowel length, this was a recent video, the bowel length was actually 8 meters. So then I kept it at 3 meters. If the bowel length was probably shorter, then I would not have probably kept it 3 meters, then that's really not malabsorptive. I might have come to 250 centimeters. So
I think in the revision, it is very difficult to predict the outcome whenever we are doing this, because there is a significant adaptation of the bowel which occurs and which leads to many times we get malabsorption and sometimes inadequate weight loss.
Absolutely, sir. Absolutely. I think still we are fighting on weight loss, and nutrition is something, the fight continues, but we hope for the best. Patients do not want nutritional complication, but they want the best weight loss. So that is the most difficult thing to balance.
Thank you, Praveen. Excellent video as usual. My question is, what about the newer endoscopic bariatric procedures? You talked about the surgical ones. Do you do any in your center? And if so, just for the, for people like me who don't do much of bariatric surgery, what's the current regarding the endoscopic bariatric procedures?
So because since your question was more focused at newer endoscopic, I'm not talking about the balloons, because that's been there for some time. I think your question is more towards an endoscopic sleeve gastroplasty. Yes, we started in our center. We still continue to do, but then very, very, very small numbers. I think for the benefit of the audience, it's basically an endoscopic device. It's an endoscopic suturing device, the Apollo overstitch, wherein we suture the stomach or plicate the stomach endoscopically to make it more like a sleeve gastrectomy. But then we do not have adequate data at this point of time on the long-term results. Yes, they seem to be working to some extent, But then on a not at a scientific standpoint, from the personal discussional standpoint, many of the procedures are already being revised. I think it is more so done from the, I mean, this is off the records, it's more so done for patients who are not willing for a surgery at this point. They end up doing a sleeve gastrectomy so that mentally they start getting prepared for the bariatric surgery at a subsequent standpoint. So that's what I was of the understanding. So even the few patients that I have done, I think not everyone, some I've already revised, but I still continue to do on patients who are probably less than 30 BMI, but who still want a bariatric procedure as such, and who's not really an hyperphagic patient. Hyperphagia, I mean, if they are really hyperphagic, a balloon itself is a wonderful procedure because a balloon gives you that restrictive effect, it really works. But if they're not that hyperphagic and they are literally like, I want a procedure, you're not in a position to give them a sleeve gastrectomy, then yes, an endoscopic sleeve gastrectomy can be considered as a procedure. It's better than the balloons, but not as effective as a sleeve gastrectomy. And we know results from the past of endoscopic, I mean, laparoscopic plication as a procedure was there, which really didn't take off well. Then a band was put over the plication. That really did not take off well. Now we cannot really expect an endoscopic plication to suddenly give us a magic. But then yes, for a very small subset, we should be ready to offer. So that's why I said, if you have it in armamentarium, it is always good.
It's a good investment for the future.
It's good for the people to learn the endoscopic suturing. So that is the only place where they can learn more suturing done endoscopy. Otherwise, it is just an exercise. For weight loss, unless until we reduce the granule level or hormonal changes, they will not have significant weight loss. I published my clinical trial of, randomized double-blind study comparing sleeve with gastric plication, and I discontinued that trial in between because of the inadequate weight loss or even complications. So, and we published in 2010, it's a 13 years, 12 years old study. So I don't think endoscopic sleeve will stay longer until it is being used, the suturing being used for something else.
Yes, absolutely. To treat complications of bariatric surgery, the endoscopic suturing is probably going to have a lot of utility. Sleeve gastroplasty, I am also. Yes.
Hi,
hello, Dr. Praveen.
And sorry to interrupt, just because we had a discussion on this endoscopic suturing as such. I think considering this is a surgical gastro audience, I think every one of us need to at least get to know about this device, because more than the bariatric standpoint, I think this will have a lot of role in other areas of gastroenterology is what I believe. Because I've been telling our centers, when we can do full thickness resection endoscopically of GIST or gastric tumors, etc., you can actually go ahead and suture this. This is probably the best suturing device that has come across after the many suturing devices that we always had in the market. And probably even we spoke about poems in the morning. If an plication or fundoplication needs to be done, this Apollo Vestige is probably a beautiful device in sense. Or maybe even, I'm not sure whether, I don't think it's really been reported, even for DU perforations or certain gastric perforations, maybe we can consider doing this as an option. But then yes, there are definitely roles of this device at multiple different gastric areas. So I think it's not only bariatric, it's a device. We are doing plication. I think it can be device used in multiple areas. Sorry, Anshuman, please.
Dr. Praveen, always full of energy. I want your guidance. What you feel that if there is a patient failure, maybe 4 or 5 years down the sleeve, it gave a good result, the patient became pregnant. Now she has again regained weight. She is relatively young. What procedure is your choice? Means what you see?
So because you, as you said, it's a patient failure because the patient has lost a good weight, she became pregnant, and then she regained back her weight. So which simply means that the sleeve worked. It also means the restriction worked. So subsequently, we need to evaluate what has really happened to the restriction. Has the sleeve dilated really much? To that extent, if sleeve has grossly dilated, there is even a possibility of a re-sleeve, although that wouldn't be my first choice. I would do that only if it was a badly done sleeve in the first place. But then my procedure of choice in these patients would be a Roux-en-Y gastric bypass, because Roux-en-Y gastric bypass is more so restrictive, some malabsorptive. So add a Roux-en-Y gastric bypass because the restriction worked. So you can give them another restriction. So that would be my first choice.
It's not only the patient failure. See, most of time we feel that we do sleeve gastrectomy and the many surgeons started doing it and they don't have a team to even follow them. So these patients may restart regaining weight, and that is the time we have to help them by controlling their hunger, which is usually there after 2 to 3 years and they started regaining. If that is the time we can control by adding some pharmacotherapy and help them, I think they can maintain weight. And as Dr. Praveen said, Roux-en-Y is, I think, the first preferred choice.
Weight regain after bariatric surgery is another big topic in itself.
Certainly.
We can go on speaking about. Any other questions? If there are any other questions regarding the previous talks also, they can be taken now. We have some spare time on our hands.
I am Dr. Saket Kumar from Patna. I have just small question that in this, sleeve plus procedures where vagus is intact and part of antrum is also there, can we encounter some long-term complication like stromal ulcer or like stricture formation at the site of anastomosis? Have you encountered in your practice or in your experience?
See, I think here we are actually removing the most of the acid-producing part of the stomach. What we're leaving behind is primarily the antrum. The acid-producing component from the antrum is way more lesser. Antrum is more so the pump, wherein it helps transfer the food from the top part to the lower part as such. So stomal ulcers are not as much as you see in a mini gastric bypass or a Rowan by gastric bypass. Yes, but the stomal ulcers still can be existent, because stomal ulcers doesn't always to do with the acid production. It's to do with the tension of the anastomosis, and then subsequently NSAID usage, smoking. There are multiple other factors that needs to be looked
I
at.
think there is a learning from the Swedish group in which they found that the longer you keep the pouch in the RYGB, the higher the incidence of stomal ulcers. It is probably something to do with added ischemia also. In a sleeve, you are keeping the blood supply completely intact from the lesser cuff. So the incidence of stomal ulcers, I believe, in the sleeve plus procedures would be less.
I think just
we
to
have
add,
to take
the
care of
anastomosis is 6 centimeters, so there is no risk of stenosis in these anastomosis.
Yes,
and I think ISG is always like a PG master class, so every faculty has completed their task before the time is over, so we got a lot of time for discussion.
Any other questions? Thank you, Dr.
Thank you.
Praveen.